Hi, my name's Ian Battersby. I'm one of the clinicians at DAVIES Veterinary Specialists and I work in the internal medicine department. And today I'm just going to talk through a short webinar on discussing, reflecting on whether antibiotics are indicated and whether that can help us modify our prescribing habits. So, changing prescribing habits sounds easier than what it is. And I find this area quite interesting, but I have still found myself in the scenario where it's a real dilemma to change a habit. And this is where you're changing from prescribing an antibiotic just in case it might be indicated, because I want to cover all bases, to only prescribing it when it genuinely is needed. And I will reflect, I've got some habits with prescribing some drugs that have evolved by an experience of 1 or 2 cases that didn't go well. So, the key is, as a group, getting a consensus, as we've talked about in the first webinar, developing a practice policy, and then and having faith, I guess, in those prescribing policies that we evolve. So, what I like to do in this topic is just reflect on a few clinical scenarios, and we can, down the camera, reflect on whether people are, would or would not prescribe antibiotics in this scenario. So, this first clinical scenario is a puppy. It's not vaccinated. It's vomiting and it's got hemorrhagic diarrhea. It's pyrexic, so it's running a fever, and it's hypovolemic and tachycardic, so in big need of fluids. So I'm sure we're all thinking that this dog's got parvo, and yes, I would, as I'm sure you all would prescribe antibiotics because they are indicated in these cases. So the next scenario is a Labrador, middle-aged, relatively bright, presented to you in your consulting room. It's had 2 episodes of diarrhea in the last 12 hours. It likes to scavenge, so we know it likes eating bits of kebab and things like that it finds out on its walk, and it's eating and drinking well, and it's well hydrated. So this is an episode of acute diarrhea, and I'd hope that you'd all agree that antibiotics are not indicated in this scenario. So the third scenario is we've got a patient that for the last 24 hours has been anorexic, lethargic, is passing diarrhea 3 times an hour, severe borborygmy, so rumbly, queasy tummy noises, and vomiting, but is able to keep drinking and keeping that fluids down. Now this scenario, would you prescribe antibiotics? It's a bit not quite as clear cut as the first 2. And I've been a bit naughty because I haven't given you all the clinical information. And because that's not a dog, it's actually me. And that's me after a barbecue where I got food poisoning. And I'm sure we've all been there. We've all had traveller's belly. We've woke up one morning when you're travelling and you've got really severe diarrhea. But at no point during that episode, well, I think most of us don't think about calling the doctor to get some antibiotics straight away. But it's interesting, if we're presented with a similar clinical scenario in our consulting room, we may be slightly more persuaded to prescribe the antibiotics. So I think that's always I think it's important to reflect on how our own management of some of these conditions rather than just how we manage what we're presented with in the consulting room. So do we follow the guidelines on a lot of the recommendations? And this was a really nice paper, focusing on the example of acute diarrhea, published by Alex German, I think in 2012. And what his group did is that they looked back on the referral histories of patients referred to Liverpool University and looked at the treatment of those patients with acute diarrhea, when they had acute diarrhea, and looked at the drugs that were prescribed. And what they found is that, unfortunately, prescribing didn't always follow the guidelines. And unfortunately, in these acute episodes of diarrhea, antibiotics were the most commonly prescribed drug. 70% of those patients were prescribed antibiotics at their first consultation. If the patient had a fever or was anorexic, it was more usual that the patient had antibiotics prescribed. But when there was no fever documented on physical examination, in 2/3 of those cases, antibiotics were still prescribed. And what's really interesting is that the longer the patient had diarrhea for, so if it'd been had diarrhea for 8-9 days before initial presentation, antibiotics weren't prescribed, or more likely not to be prescribed, which is a bit of an interesting paradox really, because a lot of acute diarrheas get better on their own. So if a diarrhea was persisting for longer than normal, you'd be more likely to think that there was an underlying issue. And I suppose in those cases diagnostics were done rather than symptomatic treatment. And a similar study this was done in a university hospital, I think published in 2011, also had similar findings that unfortunately, in only 17% of the cases where antibiotics were prescribed, there was documented evidence of infection. 45% there was a suspicion. I don't know the details of what warranted a suspicion, but there was almost 40% of the cases in that population that had no clear evidence of infection, and yet antibiotics were prescribed. So certainly something to reflect on there. And what I would say is that these studies now are getting on for 6-7 years old. So I would hope, and my impression is from certainly talking to vets on the phone, that this is changing. We're using them more responsibly all the time, and questioning when we prescribe them and whether they're indicated. So when we're prescribing an antibiotic, I guess I like to try and reflect on what is making me decide to prescribe an antibiotic. So if you've got a big, horrible, pussy open wound, that's a very open and shut kind of decision. But if we consider some of the clinical findings that we might trigger us to prescribe an antibiotic, are they specific for bacterial infections? Well, in a lot of cases they're not. There could be other reasons. So the example I'm using here is fever. So yes, if you've got a bacterial infection, you will develop a fever in a lot of cases. But there are other reasons to develop a fever, be it immune-mediated disease, viral, protozoal, fungal. And in all those cases, antibiotics are not indicated because they're not going to have an effect. So it's not saying that the next patient that presents to you with a fever should have a full workup. I guess it's just trying to make you bear in mind that if a patient presents with a fever, antibiotics may not be indicated, and to look for other information that may make you more comfortable and justify that decision. Another clinical scenario, just to review, is this is a English Bull Terrier bitch with an indwelling urinary catheter that's going to be in place for a number of times while it recovers. The placement of this urinary catheter will bypass some of the normal defense mechanisms of the bladder. So you're essentially, the urethral muscles are, the urethral tone is being bypassed. So there's a potential opportunity for bacteria to track and cause a urinary tract infection. So one argument could be that you could prescribe antibiotics just in case, or to prevent a urinary tract infection developing. However, my risk assessment of that situation is that with good hygiene measures, so keeping the urinary catheter clean, and managing it that way should hopefully prevent a urinary tract infection. But if I used antibiotics just in case and I did get an infection, well, that bacterial infection is then going to be resistant to the antibiotic I've used and be a more difficult to treat bug. So my risk assessment in this situation is that antibiotics aren't indicated. Instead, I'd keep the urinary catheter hygienic, and if I did get a urinary tract infection, the first thing I'd do is change the urinary catheter, because that's going to be the source of the bacteria, and then submit it for culture. I mean, diagnosing a bacterial infection on physical examination is challenging. Some of them are more obvious than others. And even with laboratory testing, it can be challenging. So again, it's not saying that every patient with a fever shouldn't get antibiotics. It's just, are there other reasons that will be consistent with it? And there is research ongoing to try and find diagnostic aids for us to use in our clinics. I've used the Star Trek example here. There are people researching tricorder type devices, trying to develop techniques to diagnose clinical conditions by putting a sensor on your head or taking temperatures and heart rates. And some of those objectives are to try and help you diagnose whether the bacterial infection is present or not. We're not there yet. Well, those very clever people are not there yet, but I'm sure hopefully as things move on, we may get there. One area that's quite interesting is the use of procalcitonin, which is used in some hospitals in the UK to assess whether there's a bacterial pneumonia present. So there's evidence to show that procalcitonin blood levels will increase in the presence of bacterial infections, and this has been demonstrated in a number of patients with pneumonia. So if you present to some hospitals in the UK, they will screen you for your blood for procalcitonin levels to help them make a decision on prescribing antibiotics. Those tests aren't available for us as yet as vets, but I guess we can hope that in the future they may evolve. So just to conclude the webinar, I'm just going to talk a little bit about a clinical example to talk about some of the points that we've highlighted in the first webinar and the second one, and hopefully in some of the points raised today. So this isn't my case, this is a case managed by Ronan Doyle and Rob Adams, some of the surgeons at DAVIES Veterinary Specialists. Ronan will be presenting the next webinar on surgical prophylaxis. And this is a Siberian Husky that presented with a ruptured anal gland abscess. And this was a pretty horrible infection. It tracked all the way up through the gluteals and all the subcutaneous area. So understandably, this patient needed surgical management of that infection. Area was debrided, flushed and lavaged, and they prescribed antibiotics. They prescribed, understandably, I think they prescribed amoxiclav post-operatively whilst they were waiting for cultures of the samples that they took intraoperatively. Now what's interesting is that 4 or 5 days later, this is the the culture profile that they got. They found evidence of 3 different bacteria, and as you can see, not particularly nice bacteria. Lots of resistance, and only gentamicin sensitivity is found in all 3 species. So a bit of a difficult situation. However, what's really interesting about the patient is that, on looking at this information, Rob and Ronan examined the dog and actually were just about to discharge the patient because it was doing so well. The drain was out and the wound had healed nicely. So what had happened in that scenario? Well, the antibiotics that they'd used in that scenario weren't the correct ones, but they'd influenced some of the other factors that are important in resolving an infection. So if you remember this diagram from one of the earlier webinars, where we talk about the bacterial factors and the sensitivity to the bacteria, you've got the pharmacokinetics, but also we've got the host factors. So, necrosis of tissue and the blood supply. So what Rob and Ronan had done in that scenario, by debriding and lavaging that necrotic area, they'd actually shifted the balance so that the immune system could then resolve the infection. So based on the fact that that infection had clinically resolved, we elected not to prescribe any antibiotics, and that patient has gone on to do very well. So an interesting case. I'm not saying all patients will resolve in that way, but certainly it showed how by optimizing the conditions to resolve the infection, actually in that case had a big impact. So that concludes our third webinar. I hope you've enjoyed it, and our next webinar will be hosted by Ronan Doyle, one of our soft tissue surgeons, and he'll be talking about perioperative antibiotic prescribing and ways that we can reduce it. And if you'd like to follow us on Facebook, LinkedIn or Twitter, then that will enable you to get updates on when that next webinar is released.